Thanks so much for having me here today. I'm Patrick Conway, Chief Medical Officer at CMS and Deputy Administrator for Innovation and Quality. I'm incredibly excited to be at this conference. I'm going to talk a bit about some patient safety efforts at CMS. I'm going to focus on some of our quality levers, talk a little bit about the Innovation Center and a future vision. If I learned anything from President Clinton's talk last night is I need to do a better job of weaving anecdotes and homespun stories. I'm actually from Texas, so I should know how to do this. So I will try to talk about some results, and I'll also talk about some results actually that just came in yesterday that were incredibly exciting. So our three aims at CMS: better health for the population, better care for individuals, and lower costs. I'm not going to focus much on lower costs today. President Clinton did mention this is true. We're at the lowest cost growth rate in the last 4 years in our health system since World War II, since we've been tracking. I'm going to really focus mainly on safety, better care for individuals, and better health for the population. I do talk fast, even though I've been from Texas, but that's to make sure we stay on schedule and are able to have time for Q&A. I've been Chief Medical Officer at CMS for 2 years, 8 months, and 4 days. Not that I'm counting. CMS is like dog years. I feel like I've been in this job about 2 decades. The longest serving Chief Medical Officer at CMS is 5 years. I plan to be at CMS hopefully for at least 5 years, and I focus on these three aims each and every day. It's literally on the whiteboard in my office. It's plastered around our offices. This is our focus that I'm going to talk about today. So there's 6 goals for the CMS quality strategy. I won't read them all to you, but I want to call out that the #1 goal, and it's purposely put #1, is make care safer by reducing harm caused in the delivery system. And our ultimate goal is to eliminate harm. If I ever get to revise this document, I actually will change it to eliminate harm. And we're trying to do that a number of ways. So one, in our quality improvement organization work, we actually got a huge opportunity from Congress to redesign this work. We invest hundreds of millions of dollars through quality improvement organizations focused on the Medicare population. Just a few results on the slide from previous work. 53% reduction in central line infections across the network, over 85,000 days without urinary catheters, which is directly related to lower catheter-associated urinary tract infections. And this program is actually targeting hospitals with higher than expected rates, so lower performing hospitals and bringing them into top performance. Nursing home quality, we started working with nursing homes a few years ago. We're now working with over 5,000 nursing homes across this country. That's about 1/3 of the nursing homes. I just have a few results on this slide. Antipsychotics, I had to testify right after I took my job about antipsychotics in nursing homes on the Hill. It highlighted to me what was a major issue. We've put in a national program where we've decreased antipsychotic use in patients with dementia by 15% nationally. Pressure ulcers and falls are actually down by more than 15%, almost 20% nationally in nursing homes, and reduction in healthcare-acquired infections and conditions as well. This is an adverse drug events. We've been working with INRs, Coumadin monitoring, et cetera. This example, over 2,600 patients, beneficiaries with INRs in therapeutic range. Pressure ulcers, I mentioned, we track all our results. Over 2,900 patients that don't have pressure ulcers because of the work we're doing in nursing homes. The culture change, I put this slide because it's very aligned with some of the Mark's comments as well. We are trying to shift this program into true learning networks, focusing on high reliability organizations, learning from many of the institutions that were put up around high reliability methods, about using data to drive change. And we really think innovative ideas can flow from the field. So how do we have an all teach, all learn mentality where we're getting innovative ideas from the field, spreading those best practices, also tailoring the intervention, because context does matter, to the institutions, and really focusing on clear aims and continuous testing and learning to improve results. I want to next talk about our clinical standards and survey and certification. So we set all the clinical standards or conditions of participation for healthcare providers in this country, including hospitals. We've actually significantly updated the hospital conditions of participation to focus on quality and safety issues, and plan to do more of this actually this year. We're going to update home health this year is our goal. We have not updated home health since 1989 or 81. Actually, Mark will know that, the 80s. which is too long. In the long-term care space for nursing home, we're also going to work on updating those this year. I want to talk about this survey and certification guidance. Joe and I have talked about this, and it deals with the opioid issue. So when I was at Cincinnati Children's, Steve Muthing is in the audience. I learned a lot from him about high reliability. We actually did work on opioid over-sedation in our hospital. We did find it was a problem. We then used a Ramsey score. I think Dr. Ramsey is still in the office, or here. We used high reliability methods, including real-time detection of events, learning from those events, brought down opioid over-sedation significantly, published this work in our institution. I looked at this. This is an issue where we, from our surveyors, will submit guidance nationally to guide thousands of surveyors. We have I was hoping to announce it was out, but it's still being reviewed by our lawyers. We have a guidance document focused on monitoring and over-sedation, and especially post-op monitoring, that we hope to get out very soon. And I'll tell you a personal story. I still work as a clinician on weekends. One of my team members was challenging me, this area is very clinical. Are you sure we should do this? And I literally, the weekend before, had a patient I co-manage. I work with children with multiple chronic conditions. I work as a hospital medicine physician. And I was co-managing orthopedics that week. And I had a patient where I interacted with the orthopedic resident and the nurse and tried to say, I think you're using too much of sedation, et cetera. We eventually caught it early enough that the patient did well, but did have to go to the ICU from this event. It was a classic near miss where the system did not catch over sedation. So we need to develop systems and implement systems that create a culture of safety, as was described. We work with accreditors. Joint Commission is a huge partner and collaborator, and just terrific work being done at the Joint Commission you heard about. So we're trying to enable an ecosystem that drives improvement. Transparency and value-based purchasing. So I think transparency of data and results is critical. So Hospital Compare, we run all the Compare websites and the data. Hospital Compare, for example, puts out both overall performance resorts and raw data that can be downloaded and used. We're going to do physician quality and cost data releases this year as well. So we finalize that in rulemaking. Hospital value-based purchasing, so we're measuring quality and cost, efficiency, including safety measures like healthcare-acquired conditions and healthcare-acquired infections. It moves over $1 billion a year, and I can tell you when I go to hospitals, I see those dashboards, I see people working on improvement in their system. I did have one hospital lobbyist who said to me, "You're double dinging us for our healthcare-acquired infections because you have it in the healthcare-acquired condition program and you have it in hospital value-based purchasing." My response, which was a public response, I said, "You're right. I want infections to go down. So we're going to put that measure in every single payment program we have." And I'm going to show you some results from some of that work. I'm not double dinging you. We're collectively focusing on what matters to patients. And then the Healthcare Acquired Condition Program actually was part of the Affordable Care Act, not a well-known provision, but I think critically important, where we finalize measures. We're in the performance period now, where if hospitals are lower performers, there's a negative payment adjustment. National results, this is a critical slide. Over 44% reduction in central line infections nationally. I testified on a panel right before Joe was able to share these results. Two quick stories here. One, when I have this run chart on my wall as well. I stopped our team in on one of the presentations, and I said, "Look, this is not. We should take a moment. This is thousands of lives." And I don't. When I say this, I know that we at CMS are a catalyst, and the work is really you. It's people out in the field doing this work. But collectively, we, the health system, this is thousands of lives that are being saved. Thanks. The next story I did mention, I remember as a resident a neonate that died, and at that time from a line infection. At that time, we didn't think they were preventable, which is also why I'm challenged. Sometimes I talk about harm as opposed to preventable. And we literally said to the family, the attending, these things happen, these aren't preventable. We now know, by the way, that maybe wasn't the best way to share that information, but we now know they are preventable, we are preventing them, we're decreasing that harm. Surgical site infections over 20% decreased. Early elective delivery, I don't have a slide on because I just saw the data a few days ago. Early elective delivery, which is a major risk factor for preterm birth, is down approximately 50% in this country. So it's the work of the March of Dimes and many other partners. So once again, this is not CMS work, it's collective health enterprise work. I'm going to switch, and I will talk quick. I'll switch the CMS Innovation Center and some of the work we're doing. I took over the Innovation Center approximately 7 months ago. Really exciting. For those of you who don't know, it's $10 billion over 10 years to invest in new payment and service delivery models for our health system. I mean, on some level, at one point in my life, I was a consultant for McKinsey Consulting before going to med school. On some level, this is the smartest investment ever. Like, we CMS spend $900 billion plus. Our health system spends $2.7 trillion. It's fairly obvious we should probably invest about $1 billion a year in testing new models. We're trying to move from a current state of producer-centered, volume-driven, unsustainable, fragmented system of care to people-centered, outcome-driven, sustainable, coordinated care systems. On the bottom of this slide, you don't have to go through these in detail, but there are things like value-based payment, accountable care organizations. How do we enable clinicians in the field, patients, communities to achieve the results they want in terms of better health, better care, and lower cost? This slide is probably, oh, you can read it in the gigantic font. I'll talk on just a couple models. This is a list of some of the major parts of the portfolio. The Pioneer ACOs, these were organizations that said, I want to be accountable for care for a population. The first year results were incredibly positive. So they outperformed quality results on 15 out of 15 clinical quality measures, so 100% national benchmarks. On patient experience measures, they outperformed once again on 100% on patient experience benchmarks. Their cost growth rate was 0.3%, and they generated shared savings. If the rest of our health system grew at 0.3%, our country would be financially stable. On bundles payments, we are bundling payment for acute and post-acute care. We've got hundreds of hospitals and physicians engaged in this model that say, we think we can design care better. We will save money and get better quality results for patients. Our comprehensive primary care initiative, we're paying care management fees with other payers in multiple markets on an aligned set of measures, trying to drive care coordination and better care. The state innovation models, Maryland announced on Friday, it's probably it's a very leading state now in terms of innovation. They are essentially, their hospital system, they're moving to population-based payments. The hospitals in Maryland and the state said, you know, over a 5-year trajectory, we're not paying fee-for-service. We're going to decrease healthcare acquired conditions, we're going to decrease readmissions, and we're going to do population-based payment to hospitals. And after 5 years, we're going to do population-based payments to everybody in Maryland. So this is, you know, we've got states, Arkansas, unfortunately President Clinton isn't anymore, they're doing amazing work. They are redesigning their care system to get better care, better health, and lower cost. The last one, the Healthcare Innovation Awards, you know, we invested $1 billion. We're going to make another large investment. There's several awardees in the room where we basically said, you know, test these innovative ideas across the country. Let's learn from them. This slide just shows we've got innovation in all 50 states and the territories, innovation happening broadly across the country. Partnership for Patients, I want to spend a couple minutes on. A major initiative launched by Secretary Sebelius and my first boss, Don Berwick. Bold goals, 40% reduction in preventable hospital-acquired conditions. That would be 1.8 million fewer injuries, 60,000 lives saved. 20% reduction in preventable readmissions. CMS is investing almost $1 billion in this initiative, so a major investment. We're trying to be a catalyst for change. Potential to save billions of dollars, and key here is broad engagement. Once again, this is hospitals, this is communities, this is payers, employers, you know, engaged in this effort. 10 areas of focus, from adverse drug events to injuries to obstetrical events to ventilator-acquired pneumonia. So very aligned with the work here. This slide is the Medicare readmissions. If you actually look back before 2012, I actually have this on my wall too. It was very stable around 19 to 20%, you know, 2011 and beyond. So meaning about 1 out of 5 Medicare beneficiaries would get readmitted to the hospital after they got discharged. We essentially did 2 things. We have a payment program and we have a major quality improvement investment. Both of those started around the 2011 to 2012 timeframe. 2012 drops below 19%. 2013, it is literally dropping like a rock. I'm only allowed to show this much data because they get angsty if I show you the data that's only a month old because it actually changes a bit. Our communication folks don't let me do that. But we're heading towards 17%. That's over 150,000 Medicare beneficiaries not being readmitted, staying home and healthy. Amazing results by you in the field. This is one of my favorite slides, so I'm going to try to explain it. So this is the Partnership for Patient results. There's over 3,500 hospitals. We're actually heading towards 4,000. So almost 80% of hospitals in the country engaged. The first slide is just that they're reporting quality data. That's the top blue line, the first line. The second line is improving on 5 or more healthcare-acquired conditions. So this is a significant improvement on 5 or more areas of harm. If you see around January or February, it starts being the sort of the hockey stick. So we're now above 2/3 of hospitals improving on 5 or more areas of harm. Of our 26 hospital engagement networks, which President Clinton's right, networks matter, all 26 achieved greater than 30% reduction on 6 or more areas of harm. So this is amazing national result. This bottom line I love. So the team, I said, who are your best, for each area of harm, pick the best hospitals. So by definition, it was 3% in February and March. And we basically said, let's challenge the other hospitals to reach those best-in-class results. So that bottom line, you now have 1/3 of hospitals and growing that are showing benchmark results on 5 or more areas of harm. So what and it's exactly what Mark said. It's 0 for VAP, 0 for CLABSI. This is truly benchmark results. You have 1/3 of hospitals achieving those results. I know a lot of you around this room are engaged in this work, so I want to thank you for that. This slide, I'm not going to spend too much time on. Mark talked about high reliability. This was a JAMA paper we wrote in 2008. Just to echo a few things Mark said, high reliability systems matter. We actually had a hand hygiene project. It was before we didn't have the toolkit. It was before the toolkit was available. But very similar learnings where we moved hand hygiene to 100% across Cincinnati children. Steve Muthing and others in the room did that work with us. Cincinnati Children's I've now left, so I can't take credit for it, but I started work on moving evidence-based processes from close to 0 to 100% in 120 days. We did it multiple times before I left. They've now done it multiple times over, where they can shift the whole system in the matter of a couple months. And it's high reliability methods, as Mark described. That's what we need in patient safety. It's learning from other industries about how we implement high reliability methods. It's the last slide, future vision. So technology and innovation focused on eliminating harm. I do think technology matters. I think electronic technology matters. I think Peter's right that we need to reap. We've now got sort of the baseline of electronic technology, but now how do we really redesign the systems to capture the value from that technology in terms of better outcomes and lower costs? Spreading best practices rapidly, implementing those best practices, tailoring to them to the context. Payment and incentive systems that reward eliminating harm and improving patient outcomes. So we are driving hard to move people to a value-based payment system where you're rewarded for better care and better health for your patients at lower cost. Electronic health records, monitoring and data analytics utilized to drive improvement. Learning from other industries with reliability science, lean, which Mark talked about. Within CMS, I actually started recruiting lean and other experts from other industries and putting them in CMS. So we now have one center that has done amazing results I won't show here, but decreasing contract modification time by 80%, saving full FTEs of work, and we're spreading that into the Innovation Center. We're trying to live within CMS what we want the healthcare system to be, which is highly reliable, efficient, and high quality outcomes for patients. So I actually think system redesign can achieve better health, better care, and lower costs through improvement. I'll end with one last personal story, if that's okay. 2 out of my 3 children had surgery in the last 12 months, both luckily routine surgeries that went well. Actually, both at an institution that was named as one of the ones striving for high reliability. I still, purposely, whenever I enter the healthcare system, I don't tell anyone who I am or what I do. I was scared, because it's the one. That's the exact right way to think about it. You don't want to be the one. And they didn't let me go into the OR, which I was like, Interesting. But, you know, are they doing the checklist? Do they have high reliability methods? You know, who's the anesthesiologist? Are they paying attention, or are they doing a crossword? You know, and I think we need a system where, whether it's me, it's you, your family, any beneficiary, we ensure, you know, 100 million plus people, that we have a system that eliminates patient harm for those patients. So I want to end by thanking you for your work. I want to thank Joe for having me here. This is a tremendous event. And we want to continue to collaborate and eliminate patient harm across this country. Thank you for your work. Oh, and I'm inviting Joe for the Q&A.
We're going to keep you a little longer if you don't mind.
Yes, yes.
Yes, thank you. We've got a couple of questions we want to ask Dr. Conway, please. Let me see, I'm going to sit a little closer to you.
Okay.
Please. The first question actually comes from Dr. Mike Ramsey. Patrick, what ideas do you have regarding how we might improve our national approaches to measuring reducing healthcare-associated harm across the U.S.?
Yeah, it's a great question. So a few thoughts. One, I think having valid measures and valid systems. So I didn't talk about this, but we've moved towards a measurement system that has validity checks. So in the hospital quality reporting program, if you don't pass the validity check on the data and the measurement, you actually fail the program, which is a -2%. So now hospitals have done an amazing job of collecting the data well. CDC, with their National Health NHSN network, has a very standardized process for data collection. I think now we're at a place for healthcare-acquired infections. We're actually getting there in terms of standardized, strong measurement. I think the next phase of measurement and safety, in my opinion, is what are those electronic collected measures that would really capture all-cause harm. So right now we have claims-based measures often that are not optimal. So how would you, when I was at Cincinnati Children's, we had an EHR-based measures on all-cause harm. Steve Muthing leads this work, so it's credit to him. But how do you really collect all-cause harm reliably across health systems, reward that, and improve?
Do you believe we can create this patient exchange commission, like the Securities Exchange Commission, so that we can transparently report all the harm, all the causes?
I do. So yeah, I do. I think, you know, I think the transparency and the sharing of information is critical. So I applaud you for leading that work. And I think, you know, the only way we collectively learn is if we're transparently sharing information. So I do.
This next question is from Dr. Ken Rothfield. In the recent past, CMS has used a combination of both sticks, such as payment denials for hospital-acquired conditions, and carrots, such as the Health Engagement Network and Partnership for Patients. What does the future hold for CMS in driving improvement?
Yeah, so I'll give my view. So I think it will be a combination of sticks and carrots. Partly, a lot of the sticks were literally put into law. So it'll still be a combination. I focus both internally and I think externally as well, more on the carrot side of the equation. So how do we invest in the quality improvement infrastructure? How do we really generate that change broadly? I'll say out of the Innovation Center, we're contemplating another large investment and transformation, but in the outpatient setting. So Partnership for Patients was very inpatient focused. My own personal opinion is we may need to consider a corollary large investment in the outpatient setting that would both decrease harm and improve patient outcomes. So I think that sort of what I'll call technical assistance and quality improvement support for learning networks is critical.
Something that's near and dear to my heart is opioid-based related deaths. First of all, can we eliminate the use of opioids after surgery to reduce pain?
I didn't see that question coming.
I mean, I heard about this Tylenol-based injection. I'm not a doctor, so I can ask stupid questions. Yeah. But can we, I mean, look, people use it to commit suicide. I mean, what can we do?
So here's how I'll answer that. So I think we should think about what is the effective pain treatment, and should opioids be a part of that or not, based on the patient case. Obviously, opioids are used frequently now, but I think it's a very valid question. I would say even in my own practice, sorry about that, I'll encourage teams, you know, have you thought about Toradol or other options before they sort of move to opioids? Secondly, on the monitoring, I spoke a little about this, and we've talked about this. I mean, I do think it's critical. So,
continuous or every 2.5 hours?
I think it should be tailored to the patient.
And
not. I have to be a little careful. So yes. Probably not every.
Sorry to put you.
Probably not every 2.5 hours. But actually, in all honesty, on the guidance, I mean, we actually did look at the information you provided and others. That evidence base was incredibly helpful, and we will cite that evidence base when we come out with our guidance document. And I do think it's more frequent than every 2.5 hours. I think I can say that.
Well, I think there was a slide up yesterday, so I'm going to do a little more advocacy while I'm here,
yeah.
That the brain can die within 2 to 5 minutes.
Yep.
Now, as an engineer, we have this sampling theory by Nyquist that says if you want to catch something, you have to sample for it at twice the rate that it could happen. So it implies you have to at least measure every minute. Yeah. So anyway, leave it at that.
I appreciate it.
We're so grateful that you're here. I mean, we're so grateful the Joint Commission is here. Between the Joint Commission and CMS, you have the power to really shape not only what happens in the US, but what happens in the world. And I love this investment you're making, $1 billion a year, to find how can we get better solution at the same price, or the same solution at a lower price, and disseminate it. Because one of the things we see in our industry, it takes 15 to 20 years for a good idea to become standard of care.
Yep. Yeah, the Innovation Center work has been incredibly exciting. I can't agree more. I mean, I think what I love about it too is we're trying to empower people to do the change. So at a high level, Pioneer ACOs on some level is fairly simple. We have some quality measures that you need to achieve, and then we say if you generate efficiencies, we'll share those savings. I should say, because I believe in private sector development and entrepreneurism, so also if there's something that improves patient outcomes and it comes at a higher cost, we should pay for that as well. So just to make sure I say that, sometimes people read about that it's all around cost savings. I think our major focus is on improving patient outcomes.
Thank you. Thank you for helping us save so many lives. The one plus so many. I can't wait till the springtime to hear the report. It's going to be phenomenal. Thank you so much, Patrick.
Thanks a lot.
Thank you.
Appreciate it.
Thank you.